relevant anatomy. On the right side of the lung, there are 10 segments. On the left side, there are 8 segments, as shown in the pictures. On the right, in the superior lobe, 3 subsegments: apical, posterior, and anterior. Medial lobe, medial and lateral, and the inferior lobe, superior, anterior basal, medial basal, lateral basal, and the posterior basal. Whereas in the left lobe of the lung, the superior lobe is apical, apico-posterior, and anterior, superior lingular, inferior lingular, and in the inferior lobe, superior, anteromedial basal, and the lateral and the posterior basal. Bronchial anatomy. The right bronchial tree, uh, it is divided. It is almost the length of around 1.2 centimeters. The right upper lobe bronchus is around 1 centimeter. It divides into 3 branches. One is the apical segmental bronchus, posterior segmental bronchus, and the anterior segmental bronchus. You can see on the picture on the right side, depicting with the color format. Branching pattern may be simple trifurcation or it may vary combinations of 3 branches. And next is the bronchus intermediate. After the upper lobe bronchus, the bronchus intermediate begins and the mainstem pulmonary artery crosses over this bronchus. And this is called as the eparterial bronchus because of its artery's position. Then the middle lobe bronchus, it's around 1.2 to 2.2 centimeters length, and it arises from the anterior surface of the bronchus intermediates, as shown in the picture on the right side, which is in which is below the red marking. So then it bifurcates into lateral and medial branches, and the superior segmental bronchus, which is the lower lobe bronchus, it arises from the posterior wall of the bronchus intermediates, which is known as the posterior accessory lobe. When a fissure is present, usually it bifurcates into 3 rami. The basal stem bronchus, which sends segmental bronchi to the medial basal, anterior basal, lateral basal, and the posterior segmental segments. The medial basal bronchus, it arises anterior-medially and supplies the anterior and the posterior vertebral surfaces of the lower lobe, which is in green color on the picture. Anterior basal bronchus, it arises 2 centimeters to the superior segmental bronchus, and it divides into 2 major bronchi, which is the lateral and the posterior basal bronchi. The left lateral bronchus, general features longer than the right stem bronchus. Length of the first branch. Length to the first branch is usually 4 to 6 centimeters, and it is distal to the tracheal carina. And the left upper lobe bronchus is around 1 to 1.5 centimeters in length, and it is divided into 2 branches. One is superior division and the inferior division, which is the lingular bronchus. The superior division, it ascends and commonly bifurcates into apico-posterior segmental bronchus, anterior segmental bronchus, and the variations are usually measure trifurcation if the anterior segment migrates inferiorly. The inferior division is the lingular bronchus, which is around 1 to 2 centimeters in length. It is analogous to the middle lobe bronchus on the right, and it divides into superior lingular branches, which further divides into posterior and inferior rami, and the inferior lingular branches. And the left lower lobe bronchus is around 0.5 centimeters distal to the left upper lobe bronchus. And the first branch of it is called the superior segmental bronchus, which arises posteriorly. And it usually bifurcates, but trifurcation can also occur. The basal trunk, it is distal to the superior segmental bronchus. It continues as 1.5 centimeter as a single trunk, and then bifurcates into an anterior medial basal segmental bronchus and a common stem. This common stem divides into lateral basal bronchus, posterior basal bronchus. Each basal bronchus again gives rise to multiple rami. And the normal common variations in this bronchial tree is the variations in the segmental bronchi from superior and inferior divisions of the upper lobe bronchus, and the possible presence of a subsuperior accessory bronchus from the lower lobe bronchus. These variations are usually clinically insignificant, but important during surgical resection. Arterial anatomy. The main pulmonary artery usually arises from the left to the aorta, and it travels superiorly and left anterior to the left main bronchus. It divides into the right pulmonary artery and the left pulmonary artery. The right pulmonary artery, it passes behind the ascending aorta and posterior to the SVC, and it forms a superior border of the transverse sinus and postcaval recess called the Allison's recess. The right superior pulmonary vein forms the inferior border of this recess. And this right pulmonary artery branches into the truncus anterior, which is the first branch. It arises superior laterally, posterior to the SVC, and divides into 2 branches. The superior branch of the truncus anterior, it again divides to form an apical branch, which loops posteriorly over the upper lobe bronchus to supply a portion of the posterior segment. That's the reason it is called as a posterior recurrent artery. You can see in the picture on the right, it's truncus anterior giving rise to an apical artery, which in turn gives rise to a posterior recurrent artery. The interlobar artery ongoing, the next artery is the continues as the interlobar artery. It's located between the bronchus intermediate posteriorly and the superior pulmonary vein anteriorly. It gives off posterior ascending artery to the posterior segment of the upper lobe, and middle lobar artery. It usually arises anteromedially and opposite to the posterior ascending artery at the junction of the horizontal and oblique fissure. And the superior segmental artery to the lower lobe, it arises opposite to the middle lobe artery. And the basal trunk, which is the medial basal artery, often arises along with the anterior basal artery. And the anterior, lateral, and the posterior basal arteries are the other branches of the basal trunk. You can see the picture where the middle lobar artery arising opposite to the posterior ascending artery, and the superior segmental artery arising opposite to the middle lobe artery posteriorly. The left pulmonary artery passes posterior and superior to the left bronchus, and it is longer than the right pulmonary artery. And it branches are the left in the left upper lobe. It usually has 4 branches, can also range from 2 to 7. The first branch is the anterior branch, and it is the shortest branch. The second is the posterior superior, as it passes over the upper lobe bronchus into the interlobar fissure, and it then ascending branches may arise in the fissures. As it enters the interlobar fissure, it gives to a superior segmental artery to the left lower lobe and a lingular artery. And then the basal trunk, which continues as the anterior branch, which is the anterior medial basal segments, posterior branch, lateral and the posterior basal segments. The variations in the left anterior trunk may supply the lingula. The right may have two truncus anterior arteries, which are superior and the inferior. This is again the picture showing the right upper lobe has one branch, which is the first branch is the truncus anterior, which is dividing into an apical segment and the anterior segment. This apical segment further gives to a posterior recurrent artery. And then from the bronchus intermediate arises the posterior ascending artery. Opposite to that is the middle lobe artery, and posterior to that arises the superior superior segmental artery of the lower lobe. The venous anatomy, the left pulmonary veins, superior pulmonary vein, all the tributaries of the left upper lobe, it is closely applied to the inferior portion of the pulmonary artery, and the makes dissection of the anterior branches quite hazardous in this situation. It receives the apico-posterior and anterior and the lingular veins. The common anomaly is that inferior lingular vein may also drain into the inferior pulmonary vein. The inferior pulmonary vein lies more posteriorly and inferiorly. It drains the entire lower lobe via superior segmental and common basal veins. It often joins as a common tract in more than 25% of the population. The right pulmonary veins, superior pulmonary veins has 4 tributaries, which are apical anterior, anterior inferior, and the posterior branches of the upper lobe, and the inferior branch of the middle lobe. Variation is the middle lobe vein may also drain into the atrium or inferior pulmonary vein. The inferior pulmonary vein is formed by the superior segmental vein and the common basal vein, which are superior and inferior basal tributaries. And they enter into the left atrium separately, unlike on the left side. The anatomical relationships are the pulmonary arteries run on the superior and the lateral surfaces of the bronchi. The pulmonary veins run on the medial and the inferior surfaces, and they're mostly intersegmental. The variability is more in veins when compared to the arteries and then bronchi. This is the hilar orientation of the right lung. There are 3 lobes with the horizontal the most superior and the posterior structure in the right lung is the right mainstem bronchus. The right pulmonary artery is superior and slightly posterior to the right superior pulmonary vein. And the right pulmonary veins most often enter the heart separately, which are mostly inferior. The left lung, 2 lobes with an oblique fissure. It has 8 segments. The left pulmonary artery lies the anterior and superior to the left mainstem bronchus, whereas the left superior vein is anterior and inferior to the left pulmonary artery. The greatest variation is based on the number of pulmonary artery branches. The superior and inferior veins, they usually form a common trunk before entering into the left atrium in 25% of the population. The pre-op evaluation for the pneumonectomy, according to the American College of Chest Physicians and the British Thoracic Society, there is a 3-leg protocol approach for the pre-op assessment of patients having pulmonary resections, as outlined by Peter Slinger in 2005. This assessment usually targets three areas of respiratory function: the respiratory mechanics, pulmonary parenchymal function, and the cardiopulmonary reserve. From a physiological standpoint, these three areas evaluate the oxygen transport into the alveoli, into the blood, and to the tissues, respectively. The respiratory mechanism deals with the forced expiratory volume at 1 second and the lung volumes, and the cardiopulmonary reserve the maximum amount of oxygen used at the exercise on exercise testing, and the stair climb test with 2 flights, 6-minute walk test, and exercise saturation of less than 4% variation. And the lung parenchymal testing is diffuse lung capacity of carbon monoxide. In the respiratory mechanics, the first and the basic test to undergo is the PFT, which includes a spirometry and measuring the lung volumes and diffuse lung capacity of carbon dioxide. The role of PFT is to determine the risk of respiratory complications and mortality based on the patient's preoperative lung function and the predicted function of the residual lung. In the spirometry is the most commonly used test. It measures the volume of expired air over time during a forceful exhalation that is preceded by a maximum inhalation. The forced expiratory volume at 1 second and the forced vital capacity, which is the total exhaled volume. It is the ratio of FEV1 to FVC is the key diagnostic test for common pulmonary diseases such as asthma, COPD, and interstitial lung diseases. Based on this, is the restrictive and the obstructive disease of the lung as diagnosed. The normal percentage is 70 to 80%. If it is less than 60%, mild risk of uh, post-op complication. Sorry, it is more than 60% mild risk of post-op complications. Within 30 to 60%, it is moderate risk, and less than 30%, it is indicated as high-risk patients. It is DLCO is an important test for the assessment of lung parenchymal function. It measures the efficiency of gases exchange across the alveolar capillary membrane, and it is most important in patients with emphysema, where alveolar destruction leads to an significant reduction in the gaseous exchange surface. It is a strong predictor of post-op complications than FE1, especially in lung resection and lung volume reduction surgeries. Preoperative assessment of lung function should include measurement of both the spirometric values and DLCO because these parameters characterize the function of two separate compartments of the respiratory apparatus. That is, FEV1 represents the lung volume and airflow limitations, whereas the DLCO describes the function of the alveolar capillary membrane. And the ABG is done it is of limited value in predicting post-op outcomes. Generally, PCO2 of more than 45 and PO2 of less than 65, and for desaturation of 85% on an insertion is normal. If more than 4% drop after stair climbing test is considered as a predictor of poor outcome. Predictor post-op lung function. The preoperator risk assessment for pulmonary resection, it uses both absolute and percentage predicted values of FEV1 and DLCO as recommended by the ACCP, BTS, and the European Society. The absolute thresholds are more than 1.5 liter for lobectomy and more than 2 liter for pneumonectomy are still used, but percentage predictive values are preferred as they better account for the patient-specific factors like age, sex, and race. For lobectomy, the anatomical method is usually used to estimate the post-op predicted values. In this number of segments, the post-op predicted value is measured by the pre-op predicted value into 1 minus the total functional segments, the number of segments that are removed by divided by the total functional segments. The number of segments removed is identified based on the pre-op CT scan or bronchoscopy. And for pneumonectomy, there's perfusion method is used, which is radionuclide scanning to calculate the fraction of perfusion in the lung to be resected. This is instead of the segments of the lung, it is measured by the perfusion factor, the amount of lung that is perfused. Results are then expressed as percentages of the predicted normal values, which is predicted post-op values is equal to predicted post-op by the pre-op predicted FPE1 pre-op values into 100. The risk stratification according to the predicted post-op values is if it is more than 60%, it is considered as a low risk, which so that we can proceed to the surgery. If it is between 30 to 60%, it is considered as an intermediate risk. So a further testing, which is ergonometric tests, are performed. If it is less than 30%, then it is high risk and it requires a detailed cardiopulmonary evaluation. In the ergometric testing, it includes stair climbing test, shuttle walk test, and is used to further evaluate patients in the intermediate age group. In the stair climbing test, which is the first line functional test, patients who can climb 22 meters without cardiopulmonary symptoms are considered fit for lung resection. If inability to climb more than or equal to 12 meters is associated with a twofold increase in complications and 13-fold increase in mortality compared to those exceeding 22 meters. Shuttle walk test, it involves walking between two 10-meter marks at increasing speeds. Completing more than 400 meters, there is 25 shuttles, usually indicates the fitness for surgery. Failure to meet thresholds on either test warrants a further evaluation with cardiopulmonary exercise testing. This cardiopulmonary exercise testing is a safe, objective method to evaluate cardiopulmonary function under stress and is the definitive test for assessing aerobic activity in surgical candidates. Inability to complete this test suggests that severe limited functional reserve and the poor surgical candidacy. The key parameter in this testing is the peak oxygen consumption, which reflects the overall cardiovascular fitness and it predicts the perioperative risk in lung resection. This risk stratification is based on the peak oxygen consumption. If it is more than 20 ml per kg per minute or more than 75% predicted, then it is considered as a low risk and is suitable for all types of lung resection, including pneumonectomy. If it is between 10 to 15 ml per kg per minute or between 35 to 75% predicted, it is considered as a moderate risk and elevated risk of complications, we should also proceed with caution. And if it is less than 10 ml per kg per minute or less than 35% predicted, it is considered as a high risk. Major resections are usually often contraindicated, considered remitted surgery or non-operative treatment. This is the flowchart of how to proceed with the preoperative examination and testing. In case of low risk or negative cardiac evaluation, post-op predicted values are measured, and if it is more than 60%, it is considered as a low risk and go ahead with the surgery. If it is between 30 to 60%, go ahead with the ergometric testing, which is stair climbing test and shuttle walk test. If the patient passes, then it is considered as a low risk. If they fail this test, then a cardiopulmonary testing is performed, along with the patients who have low post-op predictor value, which is less than 30%. They are considered as a high risk. And the cardiopulmonary testing, if it is more than 75%, considered as low risk, between 35 to 75%, intermediate risk, and if it is less than 35%, considered as a high risk. Spit lung functioning test, which is ventilation perfusion scan, it is recommended by the American College of Chest Physicians and British Society for patients with borderline pulmonary function, which is less than 60%, who are being considered for pneumonectomy. Uptake percentages are applied to pre-op spirometry to estimate the post-op predicted values. Both the ventilation and perfusion scans tend to underestimate usually the actual post-operative function. The ventilation scans usually show better correlation with actual post-operative outcomes than the perfusion scans. And the unilateral pulmonary arteriectomy, which is an invasive test and it is rarely performed and it is used to predict the post-op cardiopulmonary function, especially the right ventricular reserve. It is done by temporarily blocking the PA by inserting a balloon catheter into the PA or into the lobar artery, is to stimulate the reduction in the pulmonary vascular bed post-surgery. And this is used to assess the right heart's ability to handle the change in the pulmonary artery pressures after lung resection. Usually the PA, pulmonary artery pressures, and the pulmonary vascular resistance increase by around 10% and 35% respectively during exercise. It also evaluates the cardiopulmonary reserve and severe postoperative complications, acute respiratory failure due to pulmonary hypertension and core pulmonary. And the risk of this test is that catheter misplacement or migration causing arrhythmias or in sudden cardiac arrest. And also it has a risk of pulmonary thrombosis. So it is a rarely performed test. Risk assessment for pulmonary surgery, it is if the age is more than 70 years with higher extent of resection like pneumonectomy, lobectomy, and wedge receptor, with a poor exercise performance and low predicted post-op values of FEV1 and DLCO, and a prolonged operative time are considered as the higher risk patients. Whereas the low risk are with a good volume of more than 2 liters for pneumonectomy, 1.5 liter for lobectomy, and 0.6 liter for segmentectomy, and the post-op predicted value of more than 30 to 40%. If the state climbing test of more than, they are able to climb for more than 5 flights for pneumonectomy and 3 flights for lobectomy, and the cycle ergometry of more than 83 watts and the DLC of more than 40% is considered as a lower risk with maximum oxygen uptake of more than 15 to 20. The pre-op optimization, along with the pre-op evaluation of the lung functions, assessment of the other comorbidities and other organs is also important. And so risk factors through history and additional investigations and optimization of these conditions would reduce the post-op complications and also improve the surgical outcomes. Comorbidities such as hypertension, diabetes, COPD, and CKD should be evaluated pre-op and optimized accordingly. And in case of asthmatic patients, on examination, when if they have any acute episodes, it is advised to continue the bronchodilator therapy till the day of surgery. And routine blood investigations are supposed to be done. Cardiac evaluation by ECG, stress testing, and echo. Echo is for to look for any previous MI, pulmonary artery pressures, any impending heart failure. And in case of known heart diseases, additional investigations such as CT/CAG or additional conventional angiogram needs to be performed. Risk of atrial fibrillation, post-operative atrial fibrillation usually triggered by age, ischemia, atrial dilatation, volume overload, and history of heart failure. So prevention of post-op AF, usually digoxin, amiodarone, diltiazem, and magnesium sulfate are administered in the preoperative period. In our hospital, we perform giving digoxin 1 week before the surgery and continuing with 3 months post-op. And obstructive sleep apnea, patients are usually prone to hypoxia and hypercapnia, and most of them must be on CPAP. So, evaluating them pre-op would help in assessing them post-operatively with CPAP. Obesity, usually the physiological changes are supposed to reduce the lung volumes and aggravate the ventilation perfusion mismatch, but both of which lead to hypoxia, but usually not that significant. Malnutrition, patients who are underweight, BMI of less than 18.5 are usually more likely to have pulmonary complications post-operatively, such as pulmonary leaks. So nutrition is also as an important aspect in the preoperative period. So patients with low preoperative serum albumin are more likely to develop bronchopulmonary pleural fistulas and related complications following pneumonectomy. So patients who are at high nutritional risk would benefit from having the nutritional status optimized before surgery. Smoking cessation is strongly indicated weeks before surgery. It improves the pulmonary function and also wound healing. Pulmonary rehabilitation by encouraging spirometry, walking, and the pre-op period can reduce the post-op complications by enhancing the lung function of the normal lung. Surgical aspects. Pneumonectomy is an anatomic resection that consists in removal of the entire lung. Mortality after pneumonectomy is usually range between 0 to 26%. Edwards Graham is the first performed the first successful one-stage left pneumonectomy in April 1993 on James Gilmore, who is a 48-year-old physician with a biopsy-proven carcinoma of the left upper lobe. Types of pneumonectomy: standard or simple pneumonectomy. This is the most common type. In this, the removal of the entire lung with its surrounding visceral pleura. And the vascular tissue such as pleura, intercostal muscle, or omentum can be used to reinforce the bronchial stump and to prevent the stump dehiscence. Extrapleural pneumonectomy, it's a more radical surgery used for conditions like mesothelioma or extended lung cancers. It involves the removal of the entire lung, ipsilateral side pleura, parietal pleura, visceral pleura, and part of the diaphragm and ipsilateral pericardium. The graft placement may be used to replace and reinforce the surgically altered pericardium and diaphragm to prevent the cardiac herniation. Intrapericardial pneumonectomy. This procedure involves an opening of the pericardium behind the phrenic nerve, often for advanced central tumors. The graft placement is again used to replace and reinforce the surgically altered pericardium, similar to extrapleural approach. The fourth one is the completion pneumonectomy. This type of pneumonectomy is usually performed when a patient needs entire remaining lung tissue removed after a previous surgery on that lung. And the final one is the cranial pneumonectomy. This is the more complex procedure, which involves removing of the whole lung plus resection of the ipsilateral mainstem bronchus, carina, distal trachea, and includes anastomosis of the contralateral mainstem bronchus to the distal trachea. So in patients with lung or airway carcinoma with involvement of carina, this type of surgery is most commonly performed. Indications for pneumonectomy: malignant indications, centrally located tumors or bulky non-small cell lung carcinomas, synchronous ipsilateral tumors in the separate lobes, tumor invading the fissure, large adherent hilar lymph nodes involving the bronchovascular structures, primary lung carcinoma, pulmonary metastasis from colorectal cancer, sarcoma, or urogenital tumors. The completion pneumonectomy performed after ipsilateral lobectomy, indicated for local recurrence or secondary primary lung cancer. And the benign indications are destroyed lung from common chronic infections, tuberculosis, atypical mycobacterial infection, bronchiectasis, and fungal diseases such as aspergillosis. Anesthetic considerations. Single lung ventilation is usually preferred in patients with undergoing thoracic surgery, which is with a double lumen tube. The advantage of double lumen tube, it has a better suctioning, and the selective other lung ventilation or CPAP can be given to the other lung while in case of desaturation. The bronchial blocker is used for specific lobar isolation or in patients where DLT tube is not ideal because of the size, such as smaller patients. Low tidal volume is used in these patients. This reduces the risk of barotrauma and ventilator-induced lung injury, thus decreases the chance of post-op respiratory failure. In case of sudden drop in saturation, the following protocol is used, which is to increase the FiO2, check the W1 tube, ensure that the cardiac output is optimal, and should recruit the lung which is being ventilated, and then apply a PEEP to that ventilated lung, and also apply CPAP to the non-ventilated lung. And usually, intermittent reinflation of the non-ventilated lung is also performed. And the partial ventilation techniques of the non-ventilated lung, like lung oxygen insufflation, lobar insufflation, and lobar collapse using a bronchial blocker, and use mechanical restriction of the blood flow to the non-ventilated lung. In the fluid management for post-op resection surgery, the total fluid balance, positive balance in the first 24-hour perioperative period should not exceed more than 20 ml per kg body weight. For an average adult, the crystalloid admission should be limited to less than 3 liters in the first 24 hours. No fluid administration for third space fluid losses during pulmonary resection. Crystalloid should be used in preference to colloids. The urine output of more than 0.5 ml per kg per hour is unnecessary. If increased tissue perfusion is needed postoperatively, it is preferable to use an invasive monitoring anionics rather than to cause fluid overload. Position, there's a lateral decubitus position is preferred. Approaches are open approach, posterolateral, axillary thoracotomy, which is muscle sparing thoracotomy, or midline sternotomy. Minimally invasive through video assisted thoracoscopic surgery or robotic assisted. Surgical steps. The posterior lateral thoracotomy via the fifth intercostal space is a standard approach because it provides excellent access to both anterior and the posterior hilum. On entering the pleural cavity, first the careful assessment to determine the extent of the tumor is the most is important as it is the most common reason for pneumonectomy. It includes bronchoscopic assessment along at the time of surgery. In case of tumors, lymph node biopsy usually sent for frozen section to assess the resectability. Assess the hilar vessels for feasibility of complete resections. Once the decision is made in cancer diagnosis, mediastinal lymph node dissection is done. In the standard lung cancer dissection is divide inferior pulmonary ligament and dissect in the right side, dissect the nodes at 8th and 9th position, and the left side, 8th and 9th positions on the right and left side. In the posterior pleura, divide the posterior pleura and the azygous arch, dissect the level 7 lymph nodes, and on the left side, level 5 and level 6, along with the 7 lymph nodes. Then open the mediastinal pleura between the trachea and the SVC, dissect the right fourth and second nodes, and on the left side, fourth node. In the hilar dissection, the hilum is dissected to identify the pulmonary artery, superior pulmonary vein, and the inferior pulmonary vein. After retracting the lung superiorly, the inferior pulmonary ligament is divided up to the level of the inferior pulmonary vein, which is then exposed and isolated by dissecting the surrounding structures, connective tissues. On the right side, a plane should be created between the pulmonary artery and the superior pulmonary vein by dissecting it circumferentially using blunt dissecting scissors. At any time, avoid grasping the pulmonary artery directly. Instead, can handle holding the adventitia because the pulmonary artery, once it bleeds, it is very difficult to handle. After dissecting the 3 vessels, they are looped to control bleeding in case of any injury to the vessels. After the vessels are dissected, the anesthetist is alerted that the lung is going to be isolated from the circulation. It is wise to test the clamp just by clamping the pulmonary artery for a minute or two before permanently occluding it to ensure that the patient can tolerate the loss of lung. This is the image showing the retraction of the right lung and looping of the pulmonary artery, superior pulmonary vein, and the inferior pulmonary vein. The yellow one is the right bronchus. The division of the vessels can be performed by double ligation. The pulmonary end is suture ligated, whereas the medial portion is clamped and overseen with a Blalock stitch using a permanent monofilament suture or stapling or using a stapler. In case of vessels, a white stapler is used usually between two firings of a vascular stapler or using a linear cutting stapler. When the tumor involves the pericardial reflection, the pericardium is opened for more proximal vessel isolation, and a vascular clamp is applied across the atrium for division of the pulmonary vein. When the tumor is in close proximity to the proximal pulmonary artery, thus rendering it impossible to obtain a sufficient margin to apply a stapler, the pericardium should be opened to obtain additional length for division. This is a image showing the looping of the pulmonary artery. With olden days, surgeons used to prefer looping it with a finger or looping it with the blunt forceps. On the right side, mobilization of the superior vena cava is often required to encircle the proximal right main pulmonary artery. Whereas on the left side, the division of the ligamentum arteriosum produces additional length for division of the left main pulmonary artery proximally. During this maneuver, injury to the left recurrent laryngeal nerve is to be avoided. The dissecting proximally after opening the pericardium at its reflection, one can divide the left pulmonary artery at its origin, but it is important not to impinge on the right pulmonary artery when applying traction to staple the left main pulmonary artery. Then comes the division of the bronchus. The division of the mainstem bronchus should be performed as proximally as possible, 3 to 5 mm from the carina, to avoid creating an unnecessary long bronchial stump. On the right side, the carina and division site are usually well visualized, whereas on the left side, some traction on the bronchus is usually needed due to limited visibility. Peribronchial tissues and lymph nodes are cleared for exposure, but over dissection should be avoided to preserve the blood supply and to reduce the risk of poor healing and bronchopleural fistula. In right pneumonectomy, using a left-sided double lumen tube maintains isolation, allowing the safe bronchial division and stump closure. However, during a left pneumonectomy, this tube must be withdrawn into the trachea before dividing the left main bronchus, which usually abolishes the lung isolation. This leads to most tidal volume escaping through the open bronchus, and it causes inadequate ventilation and also contamination of pneumonectomy space with airway secretion. To avoid this, if the surgical margins are close to the lung cancer resection, a right-sided double lumen tube may be considered for airway management. The bronchus is then closed with a stapler, which is green color stapler is used for the bronchus. It occluded distally with a bronchial clamp and is usually divided. The surgeon must take care to select a cartridge containing samples of the proper length based on the thickness of the bronchial tissues to ensure that the bronchial closure is airtight. In patients who have received an induction radiotherapy, the right main bronchial stump should be reinforced with a vascularized tissue such as pericardial fat, pleura, pericardium, intercostal muscle flap, or an omentum. While the reinforcement of the right stump is generally advisable, it is less often necessary on the left side because the stump retracts back into the mediastinal tissues. Meticulous hemostasis is vital because postoperatively there is no lung parenchyma to tamponade even the smallest bleeding vessels or oozing vessels. This is a picture of showing the right intercostal muscle bronchial stump. Management of the post-pneumonectomy space. The goal of management of the post-pneumonectomy space is to normalize, that is, reposition the mediastinum to the midline and to prevent arrhythmias. To accomplish this, surgeons usually leave a small chest tube to evacuate a measured amount of air immediately after surgery in the operating room and then remove the tube. Some leave a chest tube with balanced pneumonectomy drainage systems like a plurivac balanced pneumonectomy drainage system to avoid mediastinal shift while maintaining the normal pressures. Alternatively, a chest tube can be placed and left clamped and intermittently unclamped briefly to reposition the mediastinum and also check the drain output. And also clamping it prevents the ascending infection. In any case, negative pressure should not be applied to the chest tube. The post-op changes after pneumonectomy. Early post-op changes, the trachea and mediastinum remain medial. The pneumonectomy cavity is filled with air, partial or mediastinal emphysema, parietal or mediastinal emphysema. The fluid accumulates progressively, air fluid level appears, and then the cavity fills 2 spaces per day and reaches upper 2/3 in 4 to 7 days. Complete filling usually takes weeks to months, and no filling suggests that complications. Trachea or mediastinal shift is to the operative side, and the diaphragmatic dome raises on the operative side, and the contralateral lung expands. In the late post-op changes, thrombus is present at the alluvial thrombus at the arterial stump, usually non-pathologic unless progressive. Secretions or fluid accumulations might be present. Tissular attenuation on the long stem, usually seen on unenhanced CT. The contrast differentiates recurrent or infections. Variable mediastinal deviation. The hard shift is possible to the to the operative site. Coastal reshaping and herniation. Parietal fat herniation at the resection site and the bronchial stump with fatty attenuation. Air is absorbed or persists as a pouch. Air is absorbed or persists as a pouch. This is a typical postoperative period, the day one pneumonectomy, which demonstrate left lung resection and the mediastinal shift to the left and the elevation of the hemidiaphragm and the presence of subcutaneous emphysema. The second X-ray is the day 4 post-op X-ray after pneumonectomy. It demonstrates 70% of the hemithorax opacification with pleural fluid and residual surgical emphysema. And third X-ray is the day 65 post-pneumonectomy, which demonstrates 100% hemithorax opacification, compensatory right lung hyperinflation, and mediastinal shift with obscuration of the heart. Post-pneumonectomy complications, early complications and late complications. Early complications are acute respiratory distress syndrome, pneumonia, pneumothorax, bronchopleural fistula, pleural emphysema, hemothorax, chylothorax, cardiac herniation, thromboembolism or pulmonary embolism, atelectasis, esophageal pleural fistula, diaphragmatic hernia, gastroparesis, anastomotic dehiscence, phrenic nerve injury, prolonged air leak, and pulmonary embolism. And the late complications include post-pneumonectomy syndrome, bronchopleural fistula, esophageal fistula, tumor recurrence, gossypium, which is surgical sponge or laparotomy pad inadvertently present, chest wall vascular fistula, anastomotic dehiscence. Acute respiratory distress syndrome, it's also called as the post-pneumonectomy pulmonary edema or acute lung injury, is usually incidence of up to 15% with mortality between 50 to 70%. It presents as a clinical syndrome of diffuse lung injury, which is acute of onset hypoxemia, bilateral lung infiltrates with no left atrial hypertension. The risk factors for ARDS is right pneumonectomy, fluid overload, extended operative period, repeated pulmonary surgery, fresh frozen plasma administration, and high ventilator pressures. They clinically present as acute dyspnea, tachypnea, hypoxemia, which may progress to respiratory failure. And it also mimics pneumonia with fever, cough, and pleuritic pain, or sepsis, including fever, tachycardia, and altered mental status. The pathophysiology involves increased pulmonary blood flow and net filtration pressures, limiting the capillary volume, endothelial damage, and lymphatic system disruption and lung hyperinflation. The diagnosis is based on the Berlin definition. Onset should be less than 1 week of insult. Bilateral opacities on the chest X-ray or CT, which is not explained by collapse or nodules, and should not be due to cardiac failure or fluid overload. Severity by partial pressure of oxygen or FiO2 with PEEP of more than 5 centimeters of water. It should be mild, moderate, and severe. Mild is 201 to 300. Moderate is 101 to 200, and severe is if it is less than 100. Management is supportive treatment with and treating the precipitating cause, mechanical ventilation, fluid balance, nutrition, and the VT prophylaxis. ECMO is used for refractory cases. Prevention strategies is intraoperatively minimize the volume overload and use the lowest tolerated FiO2. In the postoperative period, also avoid fluid overload and maintain the pulmonary hygiene. Hemothorax incidence is rare. It is an early post-surgical complication occurring around up to 4%. Causes are surgical technical issues, like example, pulmonary artery suture loosening, venous injury, residual systemic thoracic vessel bleeding, which is bronchial or intercostal branches. Risk of up to 3 to 4 liter blood can accumulate before diagnosis, which is life-threatening. Clinical features, the present dyspnea, increased oxygen requirement, decreased hemoglobin or hematocrit, and hemodynamic instability. Enlarging pleural effusion on the chest X-ray, increased bloody chest tube ICD output if present. A diagnosis is by chest X-ray, rapid effusion in untrained patients. CT shows high density effusion, which is 40 to 70 ounce per units, possibly with floculations. Look for contrast extravasation or pulmonary artery pseudoaneurysm. Management is by monitoring fluid administration, transfuse blood products, correct coagulopathy, and surgery or thoracotomy is performed if massive, more than 1.5 liter immediately or more than 150 to 200 ml per hour, can decide over a period of time. Prevention is by hemostasis, maintaining the normothermia, correct the coagulopathy and chest irrigation and organ coagulation during the intraoperative period. Cardiac herniation incidence is rare, mostly after pneumonectomy with poorly secured or large pericardial patch, which is more than 5 centimeters. Usually, the triggers for cardiac herniation are sudden intrathoracic pressure changes, such as coughing, suction, high airway pressures, chest compressions, and usually present within 24 hours and can be up to 6 months also. They present as sudden hypotension with or without cyanosis, SVC syndrome, arrhythmias, ischemia, right heart failure, chest pain, and sudden arrest. This is due to pendulous movement of the heart during inspiration and expiration, leading to kinking of the SVC and IVC, uh, which in turn causes and also arrhythmias, which in turn leads to low cardiac output and low urine output. It also mimics MI or pulmonary embolism or heart failure. High suspicion is needed. Diagnosis is done by, in case of stable patients, chest X-ray or CT is done, displaced heart, empty pericardial sac, and abnormal cardiac borders. In right pneumonectomy, apex or the right heart border shift, which is snow cone sign. In the left pneumonectomy, hemispherical left border, incisura between the great vessels and herniated chambers. In unstable patients, surgical exploration is performed immediately. Management immediate management is operative side should be patient should be positioned with the operative side up, minimize the hyperinflation, and considered 1 to 2 liter air into the hemithorax. Definitive management, emergency thoracotomy, reposition the heart and with the closed defect. Mortality is up to 50% in such cases. Prevention is by mandatory pericardial reconstruction after right pneumonectomy, optional for the left pneumonectomy. Use secure closure, bovine pericardium, and synthetic mesh. This is a chest radiograph showing the herniation of the heart into the right side and the apex of the heart returned to the normal position after rethoracotomy in the second X-ray. Postoperative atrial fibrillation, usually incidence is more with extrapleural pneumonectomy, which is 27 to 44%, whereas standard pneumonectomy it is around 4 to 25%. It usually occurs between day 1 to day 4 post-op and can occur up to day 7 to day 12. Causes are high adrenergic tone, systemic inflammation, atrial irritation, electrolyte imbalance, volume shifts. Risk factors, age of more than 65, right pneumonectomy, intrapericardial dissection, major complications. Management is by rate control or urine control with beta blockers, diltiazem, digoxin, amiodarone in the preoperative period and continuing it in the postoperative period. Correct the fluid or electrolyte imbalances. In cases of patients with unstable atrial fibrillation, use cardioversion. Persistent atrial fibrillation, you consider anticoagulation in the postoperative period with the caution of bleeding risk. Prevention is by say beta blockers in the preoperative period, IV magnesium if low, diltiazem if preserved cardiac function plus on a beta blocker. Amiodarone has intermediate to high risk in the using in the preoperative period. Pneumonia, it is a common up to 25% and serious complications after pneumonectomy, usually caused by hospital-acquired or aspiration events. The risk factors are age, COPD, previous pneumonia, alcohol abuse, diabetes, atrial fibrillation, male sex, and thoracotomy compared to a VATS procedure. Usually, diagnosis is a combination of criteria according to the Central Drug Disease Control criteria, which is imaging, new and persistent or progressive infiltrates, consolidation or cavitation on the serial X-rays, which is more than or equal to 2 serial chest X-rays with more than or one of 3 showing the radiographic findings in the adults. Symptoms and signs, fever, leukocytosis, purulent cough, dyspnea, range or worsening gas exchange. Based on the CDC criteria, more than or equal to 1 of the 3 clinical criteria plus more than 2 of the 4 pulmonary criteria is required for the diagnosis. The clinical criteria includes fever of more than 38 degrees centigrade, leukopenia with less than 4,000, or leukocytosis, which is more than 12,000 WBC. In adults, more than equal to 70 years, altered mental status without any other another cause. And the pulmonary criteria, new or worsening purulent sputum, or change in the sputum character, increased secretions, or suctioning needs. New or worsening cough, dyspnea or tachypnea, rales or bronchial breath sounds, worsening gas exchange, which is desaturation, increased oxygen requirement, increased ventilator demand. Chest X-ray is usually not alone is not alone sufficient for the diagnosis. Bronchoalveolar lavage may also be needed. Management is by antibiotics, which is the mainstay of management. Along with mycolytic therapy, bronchoscopy to clear the secretions, chest physiotherapy, and aggressive pain management. Prevention is smoking cessation, early ambulation, chest physiotherapy, and aggressive diuresis and post-op management. Chylothorax, pleural fluid triglycerides of more than 110 milligram per deciliter is considered as chylothorax. Incidence is usually less than 1% due to thoracic duct or branch injury. Usually, risk factors are extrapleural pneumonectomy and lymph node dissection. Usually, it presents within 15 days post-operative period, often after resuming oral intake. It may be asymptomatic. The possible signs are mediastinal shift, increased CVP, tachycardia, hypotension, fatigue, weight loss, epigastric discomfort, or incisional seroma. Diagnosis is made by milky pleural fluid with triglycerides of more than 110 milligram per deciliter, and the imaging is by rapidly filling space and the high chest tube output. Management is by initially evacuate the space, rehydrate the patient, and the nutrition support. NPO is the first line of management. If mild or asymptomatic, low-fat diet is given. If symptomatic patients, total parental nutrition is considered, and consider octreotide if reduced chyle flow to reduce the chyle flow. Persistent or high output patients, pleurodesis, thoracic duct ligation, or embolization is considered. This is CT scan showing chylothorax in the post pneumonectomy patient. Empyema, this is defined as pus in the pleural space post lung removal. The variants are with bronchopleural fistula, most common between 60 to 80%. High mortality occurs within 2 to 3 weeks. In without bronchopleural fistula, due to an intra-op communication like bronchiectasis, aspergilloma, destroyed lung, clotted hemothorax could be the causes. And hematogenous spread from bacteremia, example, dental abscesses. It is incidence is up to 16% after extrapleural pneumonectomy, which is more. Its risk factors are smoking, COPD, diabetes, and malnutrition. Treatment is usually steroids or antimetabolites, induction therapy, and pre-op radiation. Surgery is usually followed by right pneumonectomy, post-op ventilation, resurgery, and long bronchial stump of more than 2 centimeters are considered as the risk factors for empyema. Presentation is usually within in first one, but may occur years later also. With bronchopleural fistula, the patient present with dyspnea, chest pain, cough, serosanguinous sputum, respiratory distress, anorexia, or asthenia. And diagnosis is by laboratory investigations, which shows leukocytosis, elevated CRP of more than 100 milligram per liter, which is highly sensitive. And the imaging usually shows chest X-ray, which shows rapid air collection, air fluid levels, and CT shows biconvex collection, enhancing pleural wall air fluid levels. Bronchoscopy is used to assess the stump integrity and or the bronchopleural fistula. Thoracocentesis is usually diagnosis, but has higher risk of infection. This is a image showing the pleural empyema after left intrapleural pneumonectomy. The first postoperative X-ray in the A shows the normal surgical space with the serratus anterior muscle flap. Then the repeat X-ray is performed on the fourth postoperative period, which almost shows an increasing specification of the post-pneumonectomy space, and then followed by the actual CT images, which shows air fluid level and pleural enhancement, typical of an empyema. Management, it depends on the timing and the presence of bronchopleural fistula. If early within 3 weeks, antibiotics, chest tube drainage, VATS or irrigation, thoracotomy debridement, and bronchopleural fistula closure is performed. If it's more than 3 weeks or a failed repair, open window thoracostomy, which is Clagett or Elosius window, rib resection plus flap is considered. Muzzle or omental flap, VAC therapy, thoracoplasty, omentoplasty, and bronchopleural fistula closure is performed. Empyema necessitance is need prolonged antibiotic therapy and drainage. Mortality of following empyema is up to 71% if it is associated with a bronchopleural fistula. Prevention strategies, smoking cessation in the preoperative period, physiotherapy, optimize the nutrition, proper antibiotic prophylaxis if the infectious lung disease is considered. Surgical, in terms of surgical view, avoid the pleural contamination, protect the bronchial stump, which is by vascularized flap, avoid devascularization, which is by excessive dissection around the bronchus, and minimize the stump pressure, which is from the ventilation. Bronchopleural fistula, it is a communication between the bronchial tree and the pleural space. And is a rare and life-threatening event. Incidence is usually ranges from 1.4 to 11%, which is for standard pneumonectomy, 0.6 to 8% for an extrapleural pneumonectomy, 4.5 to 20% according to the European Society database. Mortality is between 18 to 20%. Risk factors are patient-related risk factors include anemia, diabetes, malnutrition, or smoking or COPD. Treatment is with steroids, induction therapy, and preoperative respiratory therapy. Procedural risk factors include patients with right pneumonectomy and leaving a long stump of bronchial stump of more than 2 centimeters, excessive uh, uh, dissection around the bronchus, causing devascularization of the stump, and post-op higher ventilation, higher positive pressures, and resurgery. And it is not clear whether a drain versus no drain has also caused to a bronchopleural fistula, stump closure method, stump coverage method. The clinical presentation, usually they present within the first few weeks, 50% reported within the 4 weeks after surgery. If it is less than 7 days, usually mechanical failure and suture release is usually considered. If it is between 8 to 30 days, infection, immunosuppressed patients, debilitated patients with multiple comorbidities could be the cause. And if it is more than 30 days, tumor recurrence, empyema, fibrosis could be the reason for bronchopleural fistula. The signs and symptoms are productive cough, fever, air leak, malaise, wasting, leukocytosis, and sputum, which is serosanguinous. Diagnosis is falling the air fluid level. You can see on the right side, the first X-ray has a less amount of air and the fluid, whereas the air fluid level drops in the second X-ray. CT shows stump disruption or air around the stump. Bronchoscopy confirms the bronchopleural fistula. It may miss small fistula, risk of contamination. Thoracocentesis may help, but also it has an increased infection risk. Prevention is by optimize the nutrition, avoid long or devascularized stump, and avoid prolonged post-op ventilation with higher positive pressures, and usually prefer a covering of the stump with a vascularized flap, muscle, or omentum. Management goals are the main goal is to protect the remaining lung, control the infection, close the fistula, and sterilize or obliterate the pleural space. Supportive by positioning the patient with remaining lung up to protect from aspiration, chest tube drainage, antibiotics, bronchoscopic suction, and nutrition with jejunostomy. Uh, Definitive management includes endoscopic management, in which endoscopic is preferred when the fistulas are less than 5 mm, with sealants like ethanol, polydocanol, fibrin glue, albumin glutaraldehyde, or stunt, which have low success. Whereas surgical aspects, large or failed endoscopic bronchopleural fistulas, surgical procedure is considered, which includes closure by manual or mechanical stapling, plus covering the stump with a muscle, omentum, or a pericardial flap, and a transsternal approach for complex or left-sided cases. Open drainage thoracostomy for late or large bronchopleural fistula with infected pleural space is considered. This is a 56-year-old woman with post-pneumonectomy for non-small cell lung carcinoma. A image shows 2 months post-operative, which showed dehiscence of the bronchial stump with a bronchopleural fistula. The patient presented with primary bronchial repair, omental interflap position, and clagged window. And the second one is the axial image, which shows the fat density of the omental flap. And the third image, coronal section, which shows the defect in the chest wall with high intensity of the filaments noted within the left hemithorax, which is the packaging material. Post-pneumonectomy syndrome usually refers a syndrome in which ventilation is impaired due to severe mediastinal shift as a result of distorted anatomy of the trachea after pneumonectomy. It is very rare and a late complication. usually occurs after right pneumonectomy, and it's usually its onset is between 6 months to 30 plus years post-op. It is often in patients operated in childhood or adolescence. Clinical features are decreased exercise capacity, increased work of breathing, inspiratory stridor, disburn, which causes esophageal compression, recurrent pneumonia, orthopnea, palpable heartbeat on the operative side. Diagnosis of exclusion is pulmonary function test, which is obstructive type, forced vital capacity, decreased FE1 to FVC, and also decreased peak flow, which is typical of obstructive physiology. Then a CT is performed, which shows a mediastinal shift and an airway compression. And also awake bronchoscopy is done. In an awake bronchoscopy, bronchial narrowing of the remaining bronchus with distal mucus is usually seen, or the dynamic obstruction on spontaneous esophagoscopy, which may indicate that esophageal compression. Echocardiogram, which is echocardiogram shows vascular compression. Management is by repositioning the mediastinum by saline breast prosthesis, lucite balls, or the tissue expanders. Surgery is by mediastinal adhesivolysis, phrenic nerve division. Airway support is by stent or resection if tracheobronchial malacia is suspected. Outcomes are more than 90% symptom improvement reported with mediastinal repositioning or tissue expanders. Prognosis if post-pneumonectomy syndrome left untreated, respiratory insufficiency, recurrent pneumonia, and death also might occur. Tracheobronchial malacia is associated with poor outcome. Repositioning the mediastinum with placement of tissue expanders is usually reported to improve the pulmonary function and the quality of life in patients with post-pneumonectomy syndrome. This is an image showing the mediastinal shifting causing obstruction, pulling the left medial bronchus towards the right side and causing this obstruction. This is the same X-ray CT scan, which shows the A image shows the herniation of the cardiac siloid, and B image shows a patent left mainstem bronchus, and the left main pulmonary artery shifted in a clockwise rotation around the aortic fulcrum. And the C shows the sequel of remote right pneumonectomy with complete deviation of the mediastinum into the right hemithorax and also the hyperinflation of the residual lung. And D image shows the actual view of the left main bronchus traveling anterior to the thoracic spine and posterior to the left pulmonary artery where it is getting compressed. Thank you, sir.
Good, Navya. It's quite an extensive presentation and you covered most of the topics. A few things that I would like to highlight or stress upon in a patient who's got to undergo pneumonectomy. Now, the first thing that you need to know is you cannot do a pneumonectomy unless the opposite lung is normal. That is the first thing to know. When you are assessing, you must have a normal left the opposite lung to sustain life. Second, the most of the values in the pre-op assessment are for a Western patient, a Caucasian male of 70 kgs. Many of these values may not be significant or ideal for our patients because they are of lesser body surface area. So many a time we have to resort to cases where resort to the surrogate markers like stair climbing, 6-minute walk test, and then breath holding and those sort of things in the assessment, preoperative assessment. Next, the present day situation is pneumonectomy is not a common operation. The idea is to preserve as much lung as possible. Even in malignancy, lobectomy is the ideal operation, and only when there is involvement, many a time if there is involvement of the carina, involvement of this thing, we now are resorting to sleeve resections, and then lung preservation surgery is the mainstay. Now, when you're talking about anesthetic management, double lumen tube, you must all we always do. See, many a time you people read from books. You should know what we are doing day to day in our day to day practice, and that is what you should follow. Whenever we do a pneumonectomy, we always put a double lumen tube to the opposite side. If it's a left pneumonectomy, you have a right double lumen tube, and if, vice versa. If it's a right pneumonectomy, we put a left double lumen tube. This is what is a standard practice. You go on talking from a book is not acceptable. Tomorrow, when you're going to do something on your own, it is important to know what you have seen and how it is practiced. Then your thoracotomy. One thing is you should always think about an intercostal muscle flap even before putting in a chest retractor. So as soon as you do a thoracotomy, you must harvest the lung, I mean intercostal muscle, before you put in a chest retractor. Because if you put a chest retractor already and then you decide to do an intercostal muscle flap, that muscle is already damaged. So that is important. It is like, akin to you normally put a cross clamp before you open the aorta, right?
Yes.
So similarly, you have to harvest the muscle before you do. So that for that you have to have a preoperative plan. Then pneumonectomy space management. See, again, I keep telling you, you should not follow something written in a book. What we do in our own situation, and we always put in a tube because we want to know whether there is any ongoing bleeding. And then we remove the clamp every 2 hours to know whether there is any collection. Secondly, the reason why we clamp is to prevent pendulum movement. You talked about pendulum movement in a pericardial resection. No, it happens even with an ordinary standard pneumonectomy, because if the lung is I'll call you later. If the lung is removed and the tube is kept open, there is movement of the lung because the air keeps going from that empty hemithorax out into the tube bottle and back, and that causes movement of the mediastinum, causing kinking of the SVC and IVC, giving rise to low cardiac output. To prevent that, we keep the tube clamp. And we take it out within 24 hours if there is no drainage, because we don't want ascending infection to go in. Because in our setup, in our ICUs, there is always a danger of ascending infection through the tube. Right?
Yes.
Then again, yes, you said that we use digoxin. Most of the time, we use digoxin in patients who are above 40 as a prophylactic measure to prevent cardiac failure, and more importantly, to prevent arrhythmias. Because the movement of the heart triggers of arrhythmia, so digoxin is some sort of a stabilizing this thing, and that is what we plan. We do every day. Then pneumonectomy space management. We said that, and in the later this thing, you have to make sure the incidence of a BPF usually occurs on the 5th or 7th day. So you must have a premonition, or you must have, whenever you do see the patient post-op, you must look for the early signs of development of a BPF. And the emergency management of a BPF is to put the patient on the operated side, so that the bronchial stump is away and above, that it does not spill on to the opposite side. And then you immediately make arrangements and put in an ICD. Because remember, to put an ICD in any hospital, it takes at least minimum 40 minutes to get your equipment, to get things done, and to get everything sorted out. So in that time, if you don't do this emergency procedure, then you would have already damaged the other remaining lung. So emergency management of BPF, drain, and then assess the size of the BPF. Invariably, post-surgical BPF is usually big and always, and most of the time, 90% of the time, requires re-exploration and surgical closure. All these sealants and balloons and glue and everything will not work in such patients. Remember that. Okay?
Okay.
Yeah.
Okay.
And then you talked about post, then various other things are okay. And the post pneumonectomy syndrome, most of the time nowadays, the idea is to shift the mediastinum back. So people have been
Mm-hmm.
using saline filled breast
Fillers.
prosthesis
Mm-hmm.
and things like that. Again, here lucite balls are not available anymore. They're historical things, and it requires management, active management of the post pneumonectomy syndrome, and these things can happen much later, much later
Yes.
in your in the history of the patient. So it can come
Yes, sir.
about 10 years or even 20 years later. So you have to be
Mm.
aware of this complication. And the
Yes, sir.
next most important thing, when you discharge a patient, you must tell your patient that there will be some fluid in the chest cavity,
Yes,
and nobody should intervene, put in a needle or a chest tube, because physicians outside, when they go back to their hometown, the physicians will are very this thing, oh, there is fluid there, it has to be drained, blah blah blah, and then they'll infect that space. So you have to be very careful. You have to write in your discharge summary very boldly, no intervention should be done for this space, it will get resolved slowly. And if there is any doubt, instruct the patient to come back to you rather than go from pillar to post in their own place.
okay, sir.
Understand, this may be a little
Yes, sir.
problematic in a patient who's coming from West Bengal or Bangladesh, but at least they should know that they should go and see a surgeon, and you should write there that there is going to be space, there is going to be fluid collection, because it is empty space and it will get resolved slowly, not to be intervened. So these are few practical things that you should always follow, otherwise your patients will get into trouble. Okay.
Okay, sir. Okay, sir.
Yeah, overall it was a good presentation and quite extensive. You covered most of the topics.
Yes.
Any comments, sir?
No, it's good presentation, but you could have avoided the first few, anatomical details of the segments, and because that's important for a lobectomy or segmentectomy. It's good
Yes,
for
sir.
educating again and again to stress it, but I thought could have been avoided. Then the other thing, what's the practical things we do? Of course, we do pulmonary function tests, uh, but the cardiopulmonary tests are not done very often. The VO2 max is not often calculated, but practically what we do is the staircase,
Yes, sir.
two staircase climbing with the physiotherapist of the doctor, and then see whether the oxygen saturation falls more than 4, and also the mm, SWT, walk test actually. These are the two practical things done. Then,
Yes, sir.
uh, in other cases, you may have to do cardiopulmonary function test, calculate the VO2 max and other things, and because predicting the post-operative, and there's a lot of difference between the right pneumonectomy. Of course, you mentioned that left pneumonectomy. Then the other thing is that some more details about the anesthesia and single lung anesthesia, how is it done? Previous time when we were operating, there used to be a red rubber tube, mainly for historical thing you should know, the Robert Shaw uh,
Mm.
W tube and the car lens. These were the most commonly used. Nowadays, been replaced by Portex or PVC W tubes. The Robert Shaw actually used to go to right side, and there used to be a hole for the right upper lobe. The most important thing I found was that you pass the uh, double human tube blindly, uh, and then you have to check the air entry in each segment, the upper lobe, the of both sides, lower lobe, because and then clamp and see whether it's working or not. And I found practically very often the intubation is done in the supine position, and when you shift the patient, I used to insist because I found sometimes the tube slipping. So you should
Yes.
always check it after positioning on the lateral side, again. Clamp and see whether air entry is good in all the areas of the aerated lung. Then the incision classically is a posterolateral, but then people have described the anterolateral, which I don't think is the best. And then now, of course, whether cardiac or something, transaxillary also described, but I don't know whether practically whether it is the best thing or not, because I found that trans acts for cardiac surgery, this is coming more common in the minimally invasive surgeons. Then the other
Yes.
thing is most often in our country, the cancer patients, by the time they come, they're inoperable actually. But most often we do it for destroyed lung due to
Yes.
pulmonary tuberculosis, destroyed
Yeah.
lung due to extensive bronchiectasis, lung abscess, or other problems. It's all infective procedures, I mean, infective etiologies actually. And there used to be some argument in the older time. I don't know, Sri Krishna may be able to tell you, but because many years ago they used to say that you'd uh, tie and divide the pulmonary artery first, then the pulmonary vein, and then the bronchus.
Yes,
But
sir. That is followed
they,
even now.
yeah,
Yes, sir.
but for cancer, sometimes that time the argument was that it is better. The argument for pulmonary artery is because you tie the pulmonary artery, the supply of blood to the that lung is uh, cut off, and so it doesn't become turgid with blood. Whereas if you ligate the vein ligation used to be advised that say because of cancer you are manipulating the uh, lung so much, the spread of tumor can occur. So for cancer, they used to say that better do the pulmonary vein ligation first. I don't know what exactly is the practice for those nowadays. I thought
No,
still it is pulmonary artery first. That's what I think.
we still follow pulmonary artery first, sir.
Yeah, yeah,
Only
yeah.
in case of lobectomy or in case
Yeah,
of wax, we
yeah.
do the pulmonary vein first because it is the
Easier.
superficial
Yeah, yeah,
structure.
yeah. I used to do that for right upper
Yeah.
lobectomy because the pulmonary vein is actually in front of the right upper lobe artery, for that. Anyway, uh, the other thing is postoperative pulmonary edema is at 15%. That I think is too much. I thought maybe much less, 2%, because I don't know what exact reason, maybe fluid overload, maybe because of ventilation lung injury, or maybe increased permeability. But then it may not be 15%. You said it's about 15% incidence and 60 to 70% mortality in that. That 15% I'm not very sure. Then bronchopleural fistula, I agree with uh, what Sri Krishna said. Bronchoscopy and putting the glue, that's all not going to work. The other most important thing, the cause for uh, bronchopleural fistula is some fault in surgery. Too much of bearing of the bronchus, all the tissues are taken, the vascularity is taken off. Then the other thing is leaving a stump. If you leave a stump, what happens is that uh, that area, the sputum and other thing collects. And because there's no lung, the cough and other things will not be able to expel that collected sputum and other things and gets infected. So two things. One, not bearing the stump too much, not leaving any space, so that flush with the uh, trachea. So otherwise, there will be uh, a pocket where there's a nidus of infection possible. And the right pneumonectomy, the more important to put a intercostal pedicle. The left actually, you have to go deep in the uh, space between the aortic arch, the mediastinum, and other things. So you can cover that stump. Whereas on the right side, the stump is open, and so, as Krishna said, it's better to do, especially for infective procedures, if you do, it's better to. So the usual approach is a fourth intercostal. If you are doing a intercostal pedicle, you resect the fifth rib and then prepare it before you putting your spreader and with the vascular pedicle intact actually. So, and then dental surgeons will not put a chest tube, but I think generally accepted. And what you should say in your exam is what is practiced by you. Most surgeons put a tube and clamp it because the mediastinum doesn't move. Because in an infected procedure, when the mediastinum is already fixed, that doesn't occur that much. But when you do a pneumonectomy for a cancer, that mediastinum is not fixed and stable, so it can move either way. So keep it clamped. Never use a suction. Keep it clamped. Open it 2 hours. We used to say 4 hours to see that there's no bleeding and where there's a sudden leak of bronchopleural fistula. And then clinically, if you say in the word bronchopleural fistula is when the patient suddenly spits out a lot of blood-stained fluid. The uh, first aid is actually to keep the patient with that side down. If you keep with that side open, the whole fluid in the chest cavity will go to the other good lung, and so that will drown itself, and then chest tube. Okay. No, it's better to operate on reinforce that in such cases rather than trying to do endoscopic glue and other things. And the other thing you didn't mention, what's the 30-day and 90-day mortality of the right pneumonectomy and also left pneumonectomy? What is the difference? Why is there so much difference in the mortality of the, what's the mortality of a right pneumonectomy or the mortality of a left pneumonectomy? Generally, of course, it depends on the
Percentages,
age.
we don't know.
Yeah. Generally, you
Percentages,
say it's about, it's the right is double. If the left is about
double
4,
the left, yes.
4.2, the right is exactly about 8 or 8.2. Of course, 8 to 13 or something they say, but the right pneumonectomy has much higher mortality rate than the left pneumonectomy.
The one thing I want to add is the management of the bronchial stump.
Yeah.
See, on the right side, as Sir said, it has to be minimum so that you don't leave behind a stump or a long bronchial stump. And the bronchial stump should be buried. On the right side, what we do is generally we mobilize the azygos and put it under the under the pleural flap under the azygos called azygos flap. And on the left side, we make sure that the mediastinal pleura is covered over the pericardium and the aorta so that it gets completely buried. That will prevent a bronchopleural fistula. Subsequently, if you are doing this in an infected case, you can add additional intercostal pedicle. But if you get a BPF in the later stages, then not only a pedicle is required, sometimes you may even have to mobilize the omentum from the abdomen and cover it. And that is done, and invariably that is done through the midline. Between, you dissect between the aorta and the SVC and bring it up, because that is a virgin space at that time and it is not infected. Otherwise, if you go through the same infected thoracotomy space, then again that stump will give way. So you go through a virgin clean space and then put in an omental flap and then close it completely so that you prevent a recurrence of the BPF. These are important steps that you have to know. So when you close the bronchial stump itself, you must make sure that it is completely buried inside the mediastinum, and so that it does not give rise to a bronchopleural fistula. And the earliest sign that you can recognize that the patient is developing a bronchopleural fistula is when you ask him his name or ask him to phonate. So there will be hoarseness of voice because there is leak into the bronchial, into the pleural space. So he will not be able to phonate well. Secondly, in serial X-rays, the air shadow that usually looks like a triangular space will become semicircular. So because more air is collecting in that hemithorax, so that gives you a clue that there is something going wrong. And then of course the clinical, once it completely opens up, then there is copious secretions, and then patient coughing out of frothy and blood-stained sputum, and then going into respiratory distress. So these are the ways how to detect an BPF early in the postoperative period when you do your daily rounds, and be aware of how to intervene.
Okay.
Any other questions anybody has? Any doubts? And in during the anesthetic management, the more, and also in the post-operative management, it is very important to have a very strict fluid balance control, as well as you give digoxin in patients who are above 40. Nowadays, I saw recently digoxin is coming back in a big way. In one of the groups, the Indian Association of Cardiac Surgeons, there was a lot of discussion about digoxin being revived. I don't know how many of you are aware of that or members on that group. So it is a good thing to see that people are going back to digoxin nowadays for anti-failure treatment instead of all the new ones. Are you people aware of that?
Sir, but in almost all the protocols and all the textbooks, it was mentioned digoxin was never mentioned in the preoperative period to be given. It actually they've mentioned it as digoxin is contraindicated to be given, but I couldn't find the reason also.
No,
Like,
digoxin, we don't give it this thing, but I followed this right from the time when I was a junior surgeon. My boss, Dr. Jerry Mascarenhas, used to do that, and I've had no regrets because it is an important drug. People in the West don't follow that, but I don't know. He was trained earlier in the olden days by in the UK training, but I don't know whether they do that now. But digoxin does help, and as I said, not only as an anti-failure treatment, but also to reduce the rate and prevent arrhythmias. It's a good drug to use. We have always done that. I've always done the practice that for the last 40 years. And whenever you talk, you please tell the examiner what you do in your institution. Don't talk from a book.
Yes, sir.
All of you, what you have seen, why it is done. And if you don't know the reason why it is done, ask your consultants to explain to you why it is being done that way and how it is different from what is written in the book.
Yes.
Whatever practice that you do, either thoracic or cardiac. And please, this is a fairly good presentation. You can make a little alteration what we have discussed now and put it on your drive. Okay.
Okay.
So that people will leave. Only 13 people have attended, and then after 2 months, somebody else will come back and say, "Sir, I will do pneumonectomy," because they have not attended today. This is the standard thing that happens. You don't attend your classes, and you don't know what is being discussed. So put it on the drive at least, so that other people can see.
Okay, sir.
Okay. Right, sir. Thank you very much.
Thank you. Thanks very much. Thank you.
Thank you, sir.
Thank